Quickly here, hepatitis B. Now we get into more chronic users and hepatitis B. Obviously, there is going to be vaccination involved. And in immunology and microbiology, you've covered these topics further. What I'm going to provide to you is more of a clinical background for each one of these viral hepatitis. 400 million worldwide. Obviously, you need to know this quite a bit. DNA virus with incubation. You need to know that hepatitis B is a DNA virus. Last time we talked anything about this, at some point in time, is that there's every possibility in chronicity. Two major chronic viral hepatitis that are important for you and I for pathology and cancer would be hepatitis B, which is a DNA virus, and hepatitis C, which would be an RNA virus. It's important that you know what kind of molecular goes on to cancers. Transmission here, parental or sexual routes. High risk of vertical transmission. What does that mean to you? You're thinking about a pregnant lady that is now giving birth, and during delivery, there's every possibility that through the vaginal canal, there might be vertical transmission, unfortunately, to the newborn. Think of this as being part of your torch. Hepatitis B. Leading risk factor for liver cancer worldwide. Also, keep in mind hepatitis C, and make sure that you know how to identify your hepatitis B or C. This is a DNA virus. Only 5% of adult infection develop chronic hepatitis, with the majority of perinatal infections are chronic. So there are two populations here. Very rarely do adults go on to chronicity. That would be more hepatitis C. C in hepatitis C. C for chronicity. However, could you move on to chronicity in hepatitis B? Sure you can, but a measly 5%. Still important though. Now, if it's childhood vertical transmission, that's a little bit, that's difficult. That's more challenging, and there's every possibility or likelihood of a child going on to chronicity. Clinical presentation of hepatitis B, symptomatic disease, more severe than hepatitis A, hence we're going to elaborate on it further. Jaundice rarely lasts greater than 4 weeks. So you're thinking about, if you find jaundice in a patient with hepatitis B, you're thinking about, well, this must have been a timeline of approximately 1 month. 1% incidence of fulminant hepatitis, thank goodness. Move on to extrahepatic manifestations of hepatitis B. Here you do want to pay attention to the following. Angioneurotic edema. This is important. 30% of your patients, this patient may come to you and may complain of, "Ow, doc, my tummy hurts." And also you notice that there's blood in the urine. And you find that upon serology, you find an increase in ALT. Wow, that's interesting. The liver is involved, and I'm finding abdominal pain, and I'm finding hematuria. Should be thinking about polyarteritis nodosa. 30% of your patients with hepatitis B might actually be suffering from polyarteritis nodosa. These would be adults for the most part, and the two symptoms that I gave you, hey doc, my stomach hurts, the abdominal region. Radiate to the back, no, nothing like that. And I'm finding hematuria. So you need to make sure that you're quite astute with paying attention to your patient with such symptoms. And when you say polyarteritis nodosa, obviously this is a vasculitis. The vascular system that is being affected here would be the mesenteric blood vessel. What does that vasculitis mean to you? Inflammation of your blood vessel until there's occlusion, lack of blood supply to the abdominal region, mesentery. Anytime there's ischemia, how's the patient feeling? Pain. So pain in the abdomen. In addition, you have the renal blood vessels might start undergoing microaneurysms and may result in, as I told you, hematuria. Keep that in mind. Spend a second on polyarteritis nodosa and its association with hepatitis B. Also, association with MPGN, membranoproliferative glomerulonephritis. So what does this mean to you? MPGN, what kind of symptoms? Is it strictly nephritic? Is it strictly nephrotic? Or is it both? Both. So there might be hematuria and hypertension, and there might be also massive edema, and greater than 3.5 grams of protein loss. Allow for each one of these symptoms to give you amazing information for a particular condition so that you can choose the correct answer. Stick with me and I will get you there. MPGN, nephritic nephrotic, type 1, much more common than type 2. Now we can move on. Mononeuritis multiplex. That's interesting. Mononeuritis multiplex, what does that mean? One nerve that's being affected, an inflammatory process, in multiple organs. Maybe it's a radial nerve that's affected, wrist drop. Maybe it's the common peroneal nerve, foot drop, just as an example. One nerve in which it may affect multiple systems, resulting in the sequelae that you'd expect to see. Important here as well, cryoglobulinemia. This is more so found in hepatitis C. I will tell you that right off the back. If it's any type of viral hepatitis that you're worried about with cryoglobulinemia, what does that mean to you? Allow the name to speak to you. Cryo means cold. Upon exposure to cold, because of the immunoglobulins that are involved in viral hepatitis, that upon exposure to cold, the globulins will do what? Oh, yes, they will then precipitate, right? When they precipitate, this is then referred to as being your cryoglobulinemia. During cold conditions, it then aggregates or precipitates. Interesting. So 2 major cold issues that you want to know for your boards and your wards. When you're cold and you find that the fingers are now cyanotic, that's Raynaud's, or if you find cryoglobulinemia, cold. And oftentimes, whenever you think about or you hear about a patient in which there's ascending paralysis, it's preceded by an infection, and usually viral, Guillain-Barré syndrome.